Good afternoon, everyone, and thank you for joining us today. As you know, this webcast is all about work-related asthma. So today we're going to go through a lot of things together. We're going to start with some clarification of terminology. What is work-related asthma and what are the different types of work-related asthma that are out there? We're also going to talk about the causes of work-related asthma, what kinds of symptoms you should be aware of, also how to manage this problem and what the treatment options are. I'll start before we get into the webcast by thanking and introducing the Lung Health Foundation. All of you will know the term Ontario Lung Association, but many of you will also know that the Ontario Lung Association has a new name, the Lung Health Foundation, and you see the logo on your screen. The Lung Health Foundation is engaged in the same activities that the Lung Association has been engaged in for many years, including investing in research around lung health, driving system and policy and practice change, and that means advocacy with healthcare decision makers. Also investing in different programs and supports at the practice level, often in the primary care space and in the specialty space, and also promoting awareness, particularly awareness in the public, and having a forum like this for the public to engage with experts around lung health problems is an important service that the Lung Health Foundation offers. So we encourage everyone to get to know the new brand and go to the website. You'll see that URL on your screen, and also to make use of the Lung Health Line. You see the Lung Health Line phone number on your screen. That's a line where patients out there can engage directly with a respiratory educator around questions that they may have about their own lung health. A very useful resource. So let's start by just describing how this session is going to work. We have a panel in front of us. I'm going to be moderating this session, and we'll be leaning on our panelists to share their wisdom with us and to give you those pearls that you're after in terms of learning all about how to recognize and manage work-related asthma. What is this problem? Do I have this problem? You may be wondering out there. How to identify it and how to raise this with your physician, and also how to raise it with your employer, and what to think about in terms of navigating managing this problem with both your employer and your physician. So we're going to have lots of discussion, but importantly, towards the end of the discussion, in the last 15 or 20 minutes, we're going to want to hear from you. So we're actually going to take questions that you have out there and try to answer those directly. So you'll notice that there's a comment section on your screen. When you type into that comment section, those questions that you type in come directly to us, and we'll try to go through all of those before the end of this session. So let's start with our panelists. So I'm going to start, I'll introduce myself, Samir Gupta. I'm a respirologist. I work at St. Michael's Hospital, and I'm a clinician scientist at the University of Toronto. So I'm very interested in lung health. And our expert panelist for today is Dr. Susan Tarlow, who's a colleague and a friend, and someone who I have to say is really internationally recognized for her work in the area of work-related asthma. So really the right person for us to have on our panel today. She's a professor in the Department of Medicine and in the Dalla Lana School of Public Health at the University of Toronto. She's a respiratory physician at the University Health Network at the Toronto Western Hospital, and she also works at the Gage Occupational and Environmental Health Unit of St. Michael's Hospital in Toronto. Her main areas of practice and research relate to occupational health, particularly environmental lung diseases and allergic responses, and also particularly occupational asthma. So really, I think a treat for all of us to have her here today. And then I want to introduce Fernando. And Fernando is in fact a patient of Dr. Tarlow's who has been diagnosed with work-related asthma. And he's been gracious enough to come here and join us today to share his story with us so that we can understand the patient perspective. And so I'm going to start by just going over basic terminology. And so you'll see on your screen sort of the breakdown of the different types of work-related asthma. And it's important to understand that work-related asthma itself is a sort of umbrella term. And as you can see under that, there are two main types of work-related asthma. The first is occupational asthma, or the kind of asthma that's in fact caused by the work environment. The second is work-exacerbated asthma, and that is in fact, they're completely different entities. Work-exacerbated asthma refers to a situation where somebody already has asthma. They have a known diagnosis of asthma, and that asthma is just worsened by some type of trigger in the work environment, an irritant or an allergic trigger in the work environment. What's different about occupational asthma is that it refers to folks who didn't have asthma before they entered that workspace, and in fact, the asthma was caused by that workspace, and it could have been caused by a sensitizer in that workspace, and we're going to talk all about the so-called low and high molecular weight sensitizers, which cause occupational asthma, or it could have been caused by an irritant in that workspace. Specifically, there's a type of irritant-induced occupational asthma called reactive airways dysfunction syndrome. We won't get into that in detail today. It's a kind of rarer form of occupational asthma, but we're going to talk lots about occupational asthma in general, and particularly sensitizer-induced, and a little bit also about work-exacerbated asthma. But important to recognize that occupational asthma is not a sort of blanket or umbrella term. It really is a very specific type of work-related asthma that refers to asthma that is caused and newly evolves, newly occurs due to that work environment. So now that we've gone over some of that terminology, I'm going to start with Dr. Tarlow. And I want to give the audience a sense of how big a problem this is. You know, we know that asthma is a very common problem. 1 in 3 Ontarians over a lifetime will develop asthma. But the question is, you know, how much of that is actually attributable to this concept of work-related asthma?
So there have been several studies that have looked at this question, and a conglomerate of these studies, an analysis of a combination of these studies, was published by the American Thoracic Society in 2003. And from combining all these studies, they estimated that 15% of adult onset asthma is attributed to workplace causes. This is predominantly occupational asthma, but it could include some people who may have eventually turned out to have work-exacerbated asthma with just coincidental onset of asthma while working. Similarly, an update on that was published in 2009, and the estimate there was 17.6%. So very similar. And there's a more recent study last year was published looking at incidence of asthma related to work, and that gave a slightly lower prevalence, around 11% attribution to the workplace. But either way, it's somewhere between 11 and 18%, so a significant proportion of new asthma.
Right. And obviously, asthma being a very common problem, when you get into that, you know, 10 to 18, 11 to 18%, it really means that there's a very high burden of this problem. And we know that often it's undetected because that occupational history is not necessarily being taken, and patients are, you know, people are focused on the symptoms and focused on the asthma diagnosis, but not necessarily thinking about how the workplace might be contributing to that diagnosis. So awareness is, I think, a big part of it. From the patient perspective, what kinds of signs and symptoms should patients be looking out for?
Well, for anybody who is working or has a job at the time their asthma starts, the possibility of work-related asthma, and particularly occupational asthma, should be considered. And the things that increase the likelihood is if the patient notices that their symptoms are worse during a work week and improve on a weekend off work or on holiday away from work, especially, for example, if they notice more wheezing on working days. So that should lead them to suspect that there may be something at work contributing to this, and they should discuss it further with the doctor. Ideally, the primary care physician should also be asking these questions. But as you say, sometimes the focus is more on making a diagnosis of asthma and treating the asthma rather than looking at underlying causes. So it's helpful if the patient also brings up this question to the doctor.
Right. You know, sometimes we need patients' help to sort of, you know, make us aware of what other factors might be playing a role, particularly when there's a lot happening in terms of symptoms and challenges in making a diagnosis. Sometimes can be very helpful for doctors to be prompted by patients to say, hey, you know, I just started this job. Could it be related to this? And sort of turning on that light bulb for the doctor as well, so they can go after it in that way. One of the things that I find challenging as a practitioner is, particularly around occupational asthma, we talk about sensitizer, and there are, hundreds of sensitizers that folks have identified, each one sort of associated with a different type of workplace. And I find it challenging in taking an occupational history to really make sure that I understand what types of sensitizers that patient might be exposed to in that specific workplace. So I wanted your sense, and I think helpful for patients to understand too, how do you get that information about potential workplace sensitizers, and what are the sort of maybe most important high and low molecular weight sensitizers for people to be aware of?
Yes, you're absolutely right. I mean, it's helpful for the healthcare provider to understand exactly what the patient is doing at work. And having a job title like a millwright or something like that, physicians may not know exactly what the patient is doing and what they're exposed to. So explaining it, for the patient to explain it to the doctor is very helpful, and to understand what are the things that they're working with, and also what are the things that people around them are working with. They may be working in a setting where somebody next to them is welding or soldering, and they may not be using those chemicals themselves, but they're still in the air. So they could be causing the patient's asthma. So to know about these things is very helpful. And then, as shown on the slide here, there are a number of high molecular weight and low molecular weight sensitizers. The most we divide them depending on the molecular weight of the substance. Most sensitizers are proteins, and these come from natural products. They could be from foods, from animal proteins, fungi, or enzymes. And they typically cause an allergic response, similar to the allergic response to cats or dogs. So this is, most people would find it very intuitive that these things can cause an allergic response. So that's relatively easy. And then we can follow that up usually by skin testing with these agents. And if there's a positive skin test, it adds some support to the likelihood of this causing symptoms. However, in addition to these high molecular weight agents, there are a number of low molecular weight or chemical sensitizers that are much more difficult to address. And again, in total, there are more than 300 causes of occupational asthma. Some of the common chemical causes are shown here. Most important in Ontario have been diisocyanates, which are very reactive chemicals. They're used in spray paint, polyurethane foam, and in coatings. So they're quite widely used in manufacturing and in jobs in Ontario, especially more in the past associated with the car industry. But in addition, there are other products. Colophony is present in soldering fumes. It's a pine product, also present in cleaning agents, for example. Plicatic acid is something that's present in red cedar. And then there are a number of other chemicals, amines, aldehydes, and hydrides, quaternary ammonium compounds in cleaning products, and pharmaceutical products can also cause asthma if they're inhaled. In addition, there are metal salts, for example, complex platinum salts. And these, of course, are found in multiple different occupations. So it's impossible really for anyone to memorize all these 300 causes. So that's why the starting point should be the question of whether asthma seems to be worse at work or not, and then following up with whether there is potential exposure to one of these agents.
Okay, so I mean, I think what you're saying makes sense, that you wouldn't necessarily chase this with every patient, but if a patient out there is finding that they have symptoms of asthma, like cough, wheeze, tightness of the chest, or shortness of breath, that's particularly in the workplace, then this becomes something to consider, whether there is something in that work environment that's actually caused that asthma. and bringing that to their physician. And I think then, it becomes a little bit complex to identify exactly what it might be, but I think, hopefully that process only happens in people who have that clear symptom cluster in that workplace environment. One of the things I think that has been helpful, and we've discussed in the past, is working with the employer and having the person in front of you as a physician who you suspect might have occupational asthma or even work exacerbated asthma, and really having them get a good understanding of what they're being exposed to. What kinds of documentation might a patient request from their employer to get a better understanding of that?
Well, especially for the low molecular weight, the chemical agents, it's very helpful to obtain the safety data sheets from the workplace. And the workplace is required to have up-to-date safety data sheets on all the products that are used. And any worker is entitled to get copies of these. So usually in practice, what I do is to write a short note for the patient to take to the Health and Safety Committee or their supervisor to request copies of the safety data sheets, that then they can bring those in at their next appointment, and we can look through them and see if there are known agents that are sensitizers.
So that's great advice for people out there. If you are experiencing these kinds of symptoms in the workplace, you can ask for these safety data sheets from your employer, and you can bring those to your doctor or to your nurse and have that conversation around whether any of these elements that you're exposed to could actually be the cause of your symptoms. So let's use that as a segue and actually let's talk to Fernando, because I know that Fernando, I heard from Dr. Tarlow that in fact you had a form of occupational asthma that was related to isocyanate exposure in an auto body painting shop. So, sort of coming back to exactly one of the top low molecular weight sensitizers that Dr. Tarlow had mentioned. So let's start with just, tell us about your story.
My story. Since 1973 until the 1991, I worked in the body shop. As you know, in those kind of places, there is a lot of dust and fumes and the spray. So the first 10 years, I was just only a body man. It wasn't affecting me that much. The next 7 years, I became a painter. So I was more exposed to the spray paint. Unfortunately, the 80 and the 90, they changed the paint from enamel paint, acrylic, acrylic, a clear coat paint, 2-stage. And that was the worst because all the element was in the paint that catch you breathe right away. So when I realized, like in the past year and the last year, all the time I was to paint a car, I can't even breathe. Even if you have the problem mask, get a fresh air from outside, I have a hard time to breathe. All the time I was to paint the car, I have to run outside in the wind to get a fresh air. Until we decided that something was wrong. I end up to see Dr. Tarlow. It takes almost a year time to figure out. I stay for 2 years and a half out of work until I find another job, like driving the flower shop, deliver. So it was a very clean place, and that helped me a lot. Until last year I retired. So, and but with the help of Dr. Tarlow, I'm much better, and I believe I'm in very good condition.
So it sounds like you had some very typical asthma symptoms when you were doing the spray painting. So you had shortness of breath. Did you feel tightness or wheeze or cough as well in that environment?
Yes, I started to feel I was to have a coffee all the time, a little bit, always. Okay. But when you're young, sometimes you don't think about it because I still play sport, so I was okay. Yeah. Until it became worse and worse. Okay. And that's when I decided I got to do something about it because that doesn't look normal. Right. But when there wasn't the clean, fresh air, you feel a little bit better. Right. As soon as you walk in the shop again,
back to that. And did you have this pattern that Dr. Tarlow described where you would feel much better on weekends and much worse in the work week?
Yes.
Did you have? Okay.
Yes.
And evenings were better as well.
Yeah.
As soon as you were out of that environment, you felt better.
Yeah,
Okay.
that's true.
Okay.
When you stay in the clean environment, that's when you feel a little bit better. But
Right.
as soon you go back in,
Yeah.
and even the smell, not just breathing,
Right.
affect you.
Okay. Okay. And how long did you have symptoms before you ended up seeing Dr. Tarla and
I
getting
believe a couple of years.
Okay.
It was more little.
It took
They
that
increased
long.
more and more
Right.
until I figured out
Right.
something. The way I say something was wrong. Even the company was work. They say, you know what, go away from the job and see what's your problem and come
Right.
back.
Right.
I did that. I went away for a month. I went back a couple of days, and that's when they decided to quit and find another job.
Because you got worse as soon as you went back.
Yeah.
And I think that's important for people out there to recognize that sometimes people can have symptoms for months or even years before they recognize that it's serious enough that it requires medical care, but also before they recognize that it's related to something at work. So, part of this is just awareness. And it really sometimes has to come from the patient because the doctor is not always thinking about the work environment. Doctors need to think about that more, but patients have a big role in prompting their doctors that, I think this is related to my work environment because I get much worse when I go to work. I'm better in the evenings. I'm better on the weekends. I'm better when I'm away on vacation. And these are all signs that it's a work-related problem. Ultimately, you had to change jobs. Can you tell us about the process? Was the WSIB involved? Was there a compensation piece? And did you apply for compensation? Can you tell us a little bit about
Yes.
how you managed
In the
that?
beginning, I went on the employment insurance.
Okay.
Because I don't even know if the compensation recognize you. After 7-8 months, I was in employment insurance. We sent the paper to the compensation.
Right.
I was covered by the compensation.
Okay.
So they pay me for 2 years, 2 years and a half, until they say you got to find some other job.
Okay.
And that's what I did. They never give you a problem. You have to stay under the rules,
Right.
but they cover for that for 2 years and a half.
Okay. And I think that's a really important message as well, is that there are protections for workers, and there's also a coverage that's present for people who have these kinds of complications. And if folks are in a work environment that they cannot continue in because they have work-related asthma, and in this case specifically occupational asthma, there are mechanisms for people to apply for compensation. And maybe I'll ask Dr. Tarlo to comment a little bit on what those mechanisms are like and how folks can navigate those.
So the mechanism is similar to claims for workers' compensation for injuries or for any work-related issue, medical issue. So the way that it works is that there are 3 forms that WSIB needs to receive. A claim can be initiated by the patient or by a physician or by the employer. And there are different forms for each. And each of these forms has the information about the patient, some information about the workplace, and the medical form has the medical information. And when the Workplace Safety and Insurance Board receives one of these forms, there's a form 6, 7, and 8. The medical one is the form 8. So if I send in the form 8 with the patient's permission, then WSIB will send the form 6 and 7, one to the patient and one to the employer to fill in. They'll also send the patient a form asking for a signed release to get medical records from the different doctors the patient may have seen. So they get all the medical information. They get this information from healthcare providers and the employer and the patient. And then they look at the information, they see the tests that have been done, and if they accept that this is a work-related issue, they will accept the claim and provide support. And the kind of support that can be provided from WSIB is that they can provide support if the patient needs to change their job for a period of time. So for lost income, they can provide, I believe it's 85% reimbursement for lost income. They can provide support for the cost of medications needed for the work-related condition. And they can provide support for any long-term disability, or because asthma doesn't always go away when people leave the workplace. especially if it's been present for a number of years, it often continues, even though it's usually milder. So there's some degree of impairment associated with that, and there is a disability award associated with that. So WSIB will not find a new job for people who have to leave work, but they will provide them some support. Sometimes they provide some retraining if that's needed in order to find another job, or very often they will provide support for computer skills or at least putting a resume together and looking for another job.
I think that's really important for people to know that, there actually is a lot of support out there once you recognize it. But I think the key is really recognizing that your asthma is related to the workplace. And once that's recognized, having that physician do their part, and then the employer and the patient do their part to be able to plug into this mechanism that we have with the WSIB to support people. And as we're hearing from Fernando, it works. It does seem to work, and you're able to get out of that environment without having a huge financial toll and to become gainfully reemployed then. Susan, you talked a little bit about what the WSIB would look at in terms of, is this indeed a case of occupational asthma or not? Obviously, they're going to be looking at the symptoms that the person presented with, and then they're also going to be looking at the testing that was done to prove that. Can you walk us through a little bit through the symptom clusters and what kinds of symptoms are, very highly associated with this and would predict this with a lot of certainty? And then also what kinds of tests are done and whether, how you proceed with those tests?
So first of all, the symptoms, understandably, WSIB or other compensation system would like to have an objective diagnosis and a confirmed diagnosis as far as possible. So the symptoms in general are symptoms of asthma, and it's important to get an objective diagnosis of asthma with pulmonary function tests, and sometimes we use a methacholine challenge for the diagnosis. And secondly, to know whether there's an association of symptoms with the workplace. So as we mentioned, seeing if there's a report of improvement on weekends or holidays off work. Sometimes there is improvement after work in the evenings, as was mentioned, but not always, because especially the low molecular weight sensitizers sometimes can cause what's called a late asthmatic response that can start several hours after going into work and can persist through the night. So some people go to work, and then just as they're leaving work, they may find their asthma's worse and may wake up during the night from their asthma. But when they're away on holiday, things improve. So the symptoms are symptoms, as you mentioned, of cough, wheeze, shortness of breath, and chest tightness in any combination. And then the improvement off work, and then looking at the agents that the person is exposed to. In terms of further tests, if a patient's exposed to a high molecular weight agent, for example, animals or in a bakery, flour, then we can do skin tests, and that can be very helpful, as mentioned, skin prick tests. In addition, so that would show whether there is an actual antibody response to one of these agents, but that's really not useful for these chemical agents, for the low molecular weight agents. The second part of the diagnosis is to show objectively an association of asthma with work. So we look at functional changes. We often ask people to keep a record of peak flow readings using a small peak flow meter and record symptoms and peak flows, days they're working and days they're not working. That can be very helpful. Often we combine that with a laboratory-based test, like a methacholine challenge, towards the end of a work period, a working week, and then at the end of a holiday period. And if there's a significant improvement, again, it adds more support to the role of the workplace in asthma. Finally, sometimes we go on to a specific challenge test, actually exposing the patient in a laboratory setting to materials from work, for example, isocyanates, or for a baker, exposing them to flour in a chamber in a laboratory. This is usually done in a double-blinded way, so the patient doesn't know whether they're actually being exposed to the work agent on a particular day or exposed just to something innocuous. And then we measure changes in lung function before and after the exposures, and see if there's a difference on the day with exposure to the work agent. Those are the main investigations. There are a few others that sometimes are included, such as looking at inflammatory cells in sputum, in induced sputum, or looking at exhaled nitric oxide, which is a reflection of inflammation in the airways, and looking at changes at work versus off work.
I think what we're hearing is a quite sophisticated set of tests that need to occur for us to have certainty that this is indeed occupational asthma, because of everything that happens downstream of that, which means somebody having to leave the workplace and the whole process around supporting that and reemployment. So I think we're very much talking about the role of the patient being to flag that for their physician, that their symptoms are worse at work, and the role of usually the primary care physician to think about asthma and to think about the role of work in asthma, and then getting a specialist involved so that these tests can be organized, and probably arguably not, even a respiratory specialist will often want to involve, a work-related asthma or occupational health type of specialist to help organize these tests, particularly the chamber testing, which not all patients will need that, but if it does have to happen, it obviously has to be done in a very specialized facility, and it has to be done in a safe way, and measurements have to be done before and after. So a lot of, complex testing to make sure we have the right diagnosis. And on the screen we have there some points you have about why it's important to make sure that we have the right diagnosis. And maybe you can just speak to that as well.
So certainly it's important for a compensation claim, but also it's important for the patient to have the right diagnosis, because if they have asthma that's not caused by work, but it's exacerbated by being exposed to non-specific dust at work or fumes or temperature changes that all can affect asthma, then that they may be able to stay at the same workplace, but just reduce that exposure. Whereas if it's an actual immunologic or allergic response, they need to be completely out of that environment. So the diagnosis has big implications for the patient and being able to work, and also in addition to workers' compensation. And in terms of the management. The other thing is that an early diagnosis improves the chance of asthma clearing when the person leaves the workplace. In general, unfortunately, that only happens in about 20% of people with occupational asthma, that it will go away completely. But the best chance of it clearing is with an early diagnosis at a time when asthma is relatively mild. So even though a person may not be hugely bothered at work, if their asthma is caused by work, it is important to identify it early and change that work environment.
Right. Are there implications for other workers if you identify a sensitizer?
Yeah, definitely. So in a workplace where one person has developed occupational asthma, there could be other people with a similar problem. And especially if the work exposure is high, the higher the exposure, the greater the proportion of people exposed who are likely to develop occupational asthma. So if there's a concern that exposures at work may be too high, it's very helpful to notify the Ministry of Labor to go to the workplace and make sure that that standards are being met for the other workers. And secondly, it is important for the employer to consider their other workers and to consider whether changes need to be made.
And was that, I'll ask Fernando this question, was that your experience? Were there other people in that workplace that developed a similar complication that you're aware of?
Really, I don't know. I was only another 3 or 4 guys working the same place. Like, don't get contact with them, but I don't even know. But you never know. Like maybe they can have a different symptom, and like,
Yeah, they may not.
yeah, because I don't know.
And in terms of, it sounds like you had symptoms for quite some time, which is often the case before the diagnosis was reached. After leaving that work environment, were you left with some lingering symptoms, or ultimately did it go away completely?
No, like when they left the place, the way I say, like, I still see Dr. Tarlo with all the medication, they start to clear up, and I start to feel better, but I still have, like now, the way I told him, the doctor, the only thing now I can trick my asthma, it's the smell and the smoke of the cigarette.
Okay.
Any other smoke doesn't affect me, but that, the one trick my asthma.
So
Smell and smoke of the cigarette.
that little bit of asthma still remains,
Yeah.
and there are still some triggers all these years later. And this is what gets to Dr. Tarlow's point about only about 20% of people will it go away completely. And a big part of that is because the longer you're in that environment and exposed to that, the higher the chance of having sort of long-term asthma as a result of that. A milder form of asthma, but still some symptoms of asthma with certain triggers. So again, this point we're trying to drive home around, think of it early and bring it to your physician's attention as early as possible. We've talked a lot about, what the causes are. We've talked a lot about how to make a diagnosis. We haven't talked about prevention. Can you touch on that for us, Dr. Tarlow?
So in terms of prevention, ideally, chemicals that can cause asthma would be removed from the workplace, but this is not always possible. But some agents have been removed. For example, about 15 years ago, natural rubber latex, was a big cause of occupational allergic symptoms and occupational asthma. This was in latex gloves and other products in healthcare, especially in healthcare use, but also even domestic cleaners were often using latex gloves, powdered latex gloves. Once it was recognized that this was a cause for allergy and for asthma, there were widespread changes, which is very good. So there were changes made to the gloves to reduce almost completely any powdered latex that would get into the air and cause allergic responses, and to switch from latex gloves to vinyl gloves as far as possible. So in the past few years, it's been very, very uncommon to see anybody with the new onset of latex allergy after these changes were made. So that was a very good example of preventive measures. For isocyanates, the rates have also dropped for asthma related to isocyanates in many countries. So this has been attributed to changes such as the use of polyisocyanates instead of diisocyanates. So these are slightly different chemical that are less reactive. And also to a number of changes like using robotics in companies where there previously were high levels of isocyanates, and instead of people going into those areas, the robots do the work there. Also, if people do need to go into those areas, they now wear air supply respirators to markedly reduce their exposure. So the other thing that's been introduced and has been introduced is that there's a standard for the allowable levels of isocyanates in workplaces, and that standard has come down so that the allowable levels are much lower than they used to be. So the exposure is much less, and with all of these changes, the rates have significantly gone down, but not completely disappeared. Other examples would be in hospital settings. Glutaraldehyde used to be used to sterilize endoscopes, for example, and that was a relatively common cause of occupational asthma. So recognizing that, people switched the product to something called orthophthalaldehyde, which is less volatile. But unfortunately, even that people were getting allergic responses to. And more recently, people have switched to a combination of hydrogen peroxide and peracetic acid, which it was hoped would cause less sensitization.
Lots of preventative measures being taken by employers once we're becoming aware that certain substances are sensitizers. So, I guess strategies that employees can take in terms of personal protective equipment, employers can take, providing that equipment, but also reducing exposure, changing chemicals. Can you tell us a little bit about the role of regulators, sort of at the government level? You touched a little bit about, policy changes, compelling certain industries to change. Can you tell us a little bit about what regulators have done and can do to help reduce the incidence of occupational asthma?
Well, in Ontario, there has been this regulation for isocyanates. This was introduced in 1983 at a time that isocyanate-induced asthma was it was the most common low molecular weight cause of occupational asthma. So this regulation was introduced that required monitoring of the levels of isocyanate in the workplace and also surveillance or screening of workers. So people who are going to work with isocyanates before they start working with these products need to have a respiratory questionnaire and a breathing test to make sure they don't already have lung disease, and then have these tests repeated at an annual basis, or in some cases every 6 months, so that if there are changes at work, it's hoped that they would be picked up relatively early so that these workers can then be moved out of that exposure and have the greatest chance of their asthma improving. At the moment, this is the only example of a mandated surveillance for occupational asthma in Ontario, but some other companies have voluntarily incorporated surveillance programs. For example, in the detergent industry, where enzymes have been used for detergents, that was a relatively common cause of allergic responses in asthma. And a number of companies have introduced, again, questionnaires to pick this up early and skin testing with solutions of the enzymes to identify an allergic response early and move that worker into an area where there are no enzymes.
Okay. We're going to transition to audience questions in a moment, but quickly I wanted to touch on management. It sounds like the mainstay would be to eliminate the exposure for somebody who's in, whether it's work-exacerbated asthma or occupational asthma, to eliminate exposure to whatever it is that's triggering and driving their asthma. Aside from that, and it sounds like even after removal of the exposure, symptoms can persist, can you touch a little bit on management principles? How do you help the patient get through these symptoms?
Well, certainly asthma should be treated in the same way as for people who have asthma, but it's not occupational. So we look at other triggers for asthma. Is there allergy, for example, to a cat at home, or any other allergic triggers that can be controlled? Also to advise about smoking cessation, of course, which could be another trigger. For the patient to understand their triggers and be able to control their exposure to them. Secondly, the use of appropriate medications for asthma. And in general, this is really the same group of medications that are used for people who have asthma from other causes.
Okay. So let's transition. I have a list of audience questions, and please continue to send us your questions. But let's start from the top. I've got a question about dust. And so we know that workplace dust might be a cause of somebody who has pre-existing asthma and enters a very dusty workplace, that might cause work-exacerbated asthma. The question is around distinguishing an allergic reaction to dust versus having asthma from dust, and whether you can actually have asthma symptoms from dust without necessarily having an allergic reaction to dust, like the runny eyes, the runny nose, the sneezing that people get around dust. So if somebody doesn't have those allergic symptoms, can they still have an asthma type of reaction to dust?
Well, certainly dust can irritate the airways, and depending on the level of dust, it could exacerbate or aggravate asthma in most people with asthma. But depending on the type of dust, I mean, if this is a dust from a dye, or I mean, there are many types of dust. If there are chemicals in the dust, obviously that also could cause asthma or could cause an allergic response. And although people who have an allergic airway response and asthma from an allergic response very commonly have associated nose and eye symptoms of allergy, that's not always the case. Sometimes people have asthma and don't have nasal or eye symptoms. So that needs to be considered as well. But certainly dust can exacerbate or aggravate asthma.
Okay, so there you have it. You can have an allergy to dust with the typical sort of runny eyes, sneezing, and that can trigger your asthma as well through more of an allergic mechanism. But dust can also just irritate your lungs, and if you have asthma, dust can cause an asthma reaction, even if you're not allergic to it and don't have those allergic symptoms. So those two things can travel together, but don't have to travel together. The next question is about a very specific type of exposure, something called oxivir. That's a cleaning agent that's used in hospitals. And the question is whether this might be a cause of work-exacerbated or occupational asthma, if you're aware of any cases.
Mm-hmm. So I actually received this question a day or two ago, which was good. That's right. And so I understand that this product has a combination of chemicals in it. So it has hydrogen peroxide and an acid, and there may be one or two other chemicals in this product. And this is typical of products used for cleaning. They often have several different chemicals, and it may be difficult to sort it out. So a few years ago, we would have thought that this product is something that could irritate the airways and exacerbate asthma, but probably wouldn't be a sensitizer, probably wouldn't cause asthma. However, last year there was a paper published from England about a patient who worked with this mixture for disinfection, as a disinfectant and sterilizing agent. I believe it was for endoscopes also. And this product did cause asthma in that patient. And on a specific challenge test, when this patient was exposed in a laboratory setting, they had a late asthmatic response. So their airways narrowed around 4 to 6 hours after exposure to this product and not to a control agent. So it, surprisingly, did seem to be a specific sensitizer. That was with per-acetic acid. So for this particular product, I don't think it's been reported. This is the only case report I've seen. But theoretically, it perhaps could be a sensitizer and almost certainly also would aggravate or exacerbate asthma.
Okay, so there's your answer. Sounds like some of the, not necessarily this substance or this product per se, but some of the chemicals within it have been associated with occupational asthma. And certainly if you have pre-existing asthma and you're exposed to any volatile chemical like this, it can be a cause of exacerbation. So again, work-exacerbated asthma would almost certainly be triggered by something like this in some patients. So something to consider. The next question is about Xolair, so a very specific drug that's used in the treatment of asthma, and really whether a drug like that has a role for folks with work-exacerbated or occupational asthma?
That's a very good question, actually, because especially for these high molecular weight sensitizers, for a baker or an animal care worker, for example, who's allergic to something at work that's caused their asthma, we might think that Xolair may be helpful. Xolair is a monoclonal antibody, a biologic agent that targets IgE, which is the antibody that causes allergic responses. And so it has been helpful in people who have allergic type asthma unrelated to work. In fact, there has been a report published of 10 patients with occupational asthma in whom Xolair was used with some benefit. So both on a theoretical basis and in fact, it has been shown to be helpful in some patients. Whether that is the right course to take is something that's a little bit controversial as to whether a person who has asthma, say in a bakery, should continue working in the bakery and receive Xolair, or should they change their job and their asthma may go away without these very expensive medications. So that's a question that's not really been resolved at this time, but it's something to consider.
And it might be a case by case. It might depend.
Absolutely.
It might be a place where the patient's input is really important. Some patients may not want to leave their work environment and may prefer to take a pretty, I think, invasive drug, an expensive drug, but may make that decision, whereas probably many other patients would rather leave that environment and be rid of the exposure and not have to take the drug. But interesting that there may be an option, probably more research needs to be done,
Yes.
but there may be an option that specifically would target the mechanism through which occupational asthma is occurring through this IgE mechanism that you mentioned. And this drug reduces IgE levels. So an interesting possibility there. The next question has to do with when you have the combination of somebody who has asthma, but also smokes. And the question is, it's already challenging to make a diagnosis of occupational asthma. How much more challenging is it when the person is a smoker? And what, how do you balance the contribution of the cigarette smoking versus the occupation? And how does that play into the compensation piece as well?
So certainly smoking can exacerbate asthma. And of course, we always advise all our patients to stop smoking. But in terms of the investigations for occupational asthma or work-related asthma, we're looking at changes specifically at work compared to off work. So if anything, perhaps somebody would smoke more. One might think they may smoke more when they're off work than when they're at work. So usually it wouldn't play a role in confounding the diagnosis too much, but it's something to take into consideration.
Right.
And certainly to quit smoking.
Maybe driving the asthma in general,
right?
But that work relationship should still be evident with a worsening at work.
Right.
But yeah, important to recognize that asthma is strongly triggered by cigarette smoking. So this is obviously an asthma trigger as well, and that asthma medications are known to be much less effective in cigarette smokers because that is a very potent inflammation type of trigger that one is breathing in and making those medications less effective. So probably the diagnosis can still be made, but the probably equally important to removing that patient from the work exposure is helping that patient to quit smoking. Another, probably the last question that we're going to have for today is a question around methacholine challenge testing. And you touched on this as this is a very specific test that's done for asthma. And the question is whether somebody who's already had a methacholine challenge test and already had the proof of that diagnosis, in the context of making a WSIB claim around occupational asthma, would they need another methacholine challenge, or having had one in the past would be sufficient?
So the methacholine challenge is helpful in two ways. First of all, for the diagnosis of asthma per se. So if the baseline breathing tests are normal, methacholine challenge can show changes that support asthma for whatever reason, even if somebody has asthma unrelated to the workplace. So it's helpful for the diagnosis of asthma. In the context of work-related asthma, it is helpful to repeat the test towards the end of a working week and after a period of time off work to see the changes that would support a role for the workplace. Having asthma with one methacholine challenge supporting a diagnosis of asthma doesn't prove that the person's asthma is work-related.
So with that, I think it's time for us to wrap up. We're in the last few minutes of the webcast. We'll put up some slides that would just highlight some key points and sort of summary points that Dr. Tarlow wanted to make sure that the audience leaves with. I'll take this opportunity to thank our guests. I'll thank Dr. Tarlow for her expertise and thank Fernando for giving us a really nice firsthand account and driving home some of these points. I think that it worked really well with you sort of talking about these sensitizers and you having had an experience with one of these common sensitizers and how that played out for you. For the audience, the conversation doesn't have to stop here. This will be available to you on the Lung Health Foundation website. You have the website information on the screen. You can watch this again and again if you wish. There are lots of other important and useful educational material that you can consume through the website. Don't forget the Lung Health Line if you're a patient and you have questions. We've had some good questions here today, but you may have other questions. And the Certified Respiratory Educator on the Lung Health Line can be very helpful for that. So with that, we will wrap up and thank you all for attending and for your attention and your questions today.